The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. In today's podcast, we're going to go over the new published global definition for ARDS. You know, one of the things that we have seen change is technology. And I love this new definition. Definitely was excited to read this. Got to thank Dr. Michael Loria for sharing it with me when it was released. Got to remember, since 2012, we've focused on really treatment based on the Berlin definition of ARDS. And we know that several developments have supported the need for really a review, the expansion of the definition, including, as I said, the technology that's now available, not only within the hospital system, but now in the pre-hospital system, things like high-flow nasal cannulas, and the expansion of using tools like pulse oximetry in place of maybe your ABG. And we know that not every program, definitely EMS agencies, don't have the capabilities of looking at ABGs. The use of maybe ultrasound for chest imaging, and really the need to apply different processes based on limited resource hospitals or settings. So they came together and they had a consensus conference where they pulled together 32 of the top critical care ARDS experts from around the world. They had multiple virtual meetings between June of 2021 and March of 2022, and came away with really points of emphasis to give to the different critical care societies. So let's come back and look at specifically the definition, or the Berlin definition, the definition that we've been using for the last 11 years. Remember, the Berlin definition took the place of the American European consensus. Really, the Berlin definition got rid of the term acute lung injury, and it gave us three specific target areas from mild, moderate to severe. And that is looking at really the ratio, or PaO2 FiO2 ratio. Mild would be considered anything less than 300 millimeters of mercury with the addition of PEEP or CPAP, and that PEEP or CPAP had to have a level of 5 centimeters of water. Moderate would be considered a PaO2 FiO2 ratio less than 200, again with a minimum of 5 of PEEP. And severe, if you remember, was a PaO2 FiO2 ratio less than 100, again with the PEEP of 5 as a minimum starting point. Remember, had to have an acute onset, had to have bilateral infiltrates or opacities, and that respiratory failure had to be unexplained outside of cardiac failure. So we wanted to make sure that there was no cardiac failure, no volume overload. And in the past, we looked specifically at, do you have a pulmonary capillary wedge pressure that is greater than 18? We know that you have to have a Swan-Ganz catheter in place, and that's not the norm. So really, ARDS had to be differentiated from pneumonia or CHF. And remember, CHF would be characterized as that fluid overload, whereas ARDS does not show any signs of left atrial hypertension or overt volume overload. So what is wrong with the Berlin definition? Well, again, remember, we don't all have ABG capabilities. And if you don't have an ABG, you can't truly define that PF ratio. That PF ratio was really significant when it came to that diagnostic level from mild to severe. Now that we've broken down the Berlin definition, let's look at really what prompted the consideration for expanding this definition. Number one, non-invasive pulse oximetry methods for evaluating oxygenation criteria really in ARDS have been validated and applied now in observational studies and clinical trials. So in the past, really, their only way to really truly evaluate oxygenation status was that PaO2 FiO2 ratio, which made it almost impossible for a lot of places, emergency medicine, all the way to EMS agencies for truly diagnosing a patient in ARDS based on that mild to severe criteria. Number two, we know the use of high-flow nasal cannula technology to manage severe hypoxemia and respiratory failure increased over the past 8 years, and it's become widespread, especially since the COVID-19 pandemic. Patients with acute hypoxic respiratory failure are now managed very, very successfully with high-flow nasal cannula. But remember, that does not meet that Berlin definition of ARDS, which requires invasive or non-invasive mechanical ventilation with a PEEP of 5. And so that really does throw a wrench in the overall ability for us to diagnose. Third, the Berlin definition really is problematic for those resource-limited areas or settings. Number one, if you don't have chest x-ray capabilities, if you don't have ABG capabilities, if you don't have the ability to apply a mechanical ventilator, again, you have to have 5 of PEEP, then you really are limited in your ability to diagnose. And so really looking at this, ultrasound now imaging has increased, and we know it's increased as far as education across the industry, and it's now being used in critically ill patients with not only acute hypoxic respiratory failure, but sometimes in supplementing traditional chest x-ray technology. So those are just 3 areas that really brought forth the thought process of, hey, we should relook at this based on the new technology out there and based on current evidence. Again, you don't have an ABG, can we use pulse oximetry? Before we continue with the new criteria, I think it's important that we review pseudo-ARDS and the thought processes around pseudo-ARDS. Remember, true ARDS is more uncommon than originally thought or diagnosed. And in most cases, iatrogenic causes are really the guiding force in progressing patients to what we classify as ARDS. And those include, obviously, volume overload, keeping way too much fluid, pulmonary effusions, and lung collapse or atelectasis. So when we look at the volume overload side, remember initial injury causes non-cardiogenic pulmonary edema when we give way too much fluid. Remember the whole 30 mils per kilo. And that volume overload on top of this, when you give this large amount of fluid, let's say you have a morbidly obese patient, that just causes a big problem and makes these patients much sicker. When we look at pulmonary effusions, really appears to have ARDS etiology, but has bilateral effusions with lung collapse or atelectasis. These can be missed on a semi-supine chest x-ray due to that posterior layering of fluid. It's much more sensitive to use CT scan technology to really diagnose these patients, but what they found is drainage of these effusions results in rapid improvement. When we look at just atelectasis, most commonly in lower lobes, especially in the obese intubated patient, can look very similar to ARDS on a chest x-ray, but we got to remember its only reliable way to diagnose is improvement with increased mean airway pressure. So it's all about understanding that we have all been taught lung protective strategy. And so we know that let's keep that plateau pressure less than 30, or even better, let's keep driving pressures less than 15. And by doing that, we often use very low tidal volume. What they've recognized, though, is that lung collapse, those little airways that are collapsing, they need to be recruited. So it really is important to, within that first 24 hours, to be a little bit more aggressive, use higher mean airway pressures. APRV is a great way to achieve this, but higher PEEPs might be utilized. And this is where really the Berlin definition tries to weed out pseudo-ARDS by requiring at least 5 of PEEP. But again, if you're in a limited resource area where you don't have mechanical ventilation, you can't apply 5 of PEEP, then that is not going to work. But we got to remember, this is likely insufficient to establish adequate recruitment. 5 of PEEP is nothing. Looking at pseudo-ARDS and making sure we're not causing worse outcomes by just conventional therapy. So what were the results? What were the recommendations? Well, the committee made 4 main recommendations that I think are exciting. Number 1, to include high flow nasal cannula technology with a minimum flow rate of greater than 30 liters a minute. Number 2, to use an arterial oxygen tension, so PaO2, FiO2 ratio of less than 300, or, here's the big one, an SpO2, FiO2 ratio less than 315, only if the SpO2 is less than or equal to 97%. So that is simple, right? Most of us are below 97%, and that is ultimately to identify that hypoxemia. Number 3, to retain bilateral opacities for imaging criteria, but added ultrasound as an imaging modality. So they're going to keep the bilateral involvement. Remember, standard ARDS patients are going to have bilateral involvement, acute onset. We'll talk about the acute onset aspect, but really the bilateral involvement, ground glass appearance is one of those key diagnostic areas. So adding ultrasound as an imaging modality, especially in those resource-limited areas. And number 4, in resource-limited settings, do not require PEEP, oxygen flow rates, or specific respiratory devices as a diagnostic factor in looking at these ARDS patients. And I think that that is really, really cool. So if we look at the Berlin definition, we look at the rationale for updating the criteria and how it's addressed in the global definition. Let's go through these 4 categories. So when we look at the Berlin definition and we round that out with why are they updating the criteria and how was it addressed in the global definition, let's look at these 3 criteria. Remember, the Berlin definition was all about acute onset, within 1 week or known insult of new or worsening respiratory symptoms. So when you look at the rationale for updating that criteria, onset may be more slow, right? It might happen over a longer period of time, such as we saw with COVID-19. So how did the global definition address that? Well, the inclusion of patients with high flow nasal cannula will capture patients with that more slow onset, and therefore the timing criteria has not been changed. Number 2, bilateral opacities on chest radiograph or CT scan, not fully explained by effusions or any lung collapse. And so when you look at the rationale for updating, it gives chest x-ray and CT scan are not always available in some of these clinical settings. And they address this by adding ultrasound. Remember, ultrasound can be used to identify bilateral loss of lung aeration. Multiple B lines and or consolidation would be identified on your imaging as long as the operator is well trained in the use of ultrasound. And lastly, the 3 severity categories defined by the PF ratio. Remember, PF ratio really was everything. The requirement for invasive or non-invasive mechanical ventilation with a PEEP of 5 or greater, required for all categories of oxygenation severity except mild, which can be also met with CPAPs greater than or equal to 5. So the way they looked at this from the rationale standpoint is pulse oximetry measurement, we know, is widely used. We all have this capability, and it's been validated as a good surrogate for PaO2 FiO2 ratio. By adding the high flow nasal cannula and using this across the industry, right? We've seen this increasingly be used in patients with severe hypoxemia very successfully. who otherwise met ARDS criteria. And lastly, invasive and non-invasive mechanical ventilation is not always available in these resource-limited areas. The way they addressed that was, again, the SpO2 FiO2 ratio. Remember, if it's less than 315, it can be used for diagnosis and assessment of severity if SpO2 is less than or equal to 97%. So again, lots of us are, if not all of us, are probably sitting right there at 97% or low. So really allows us a wide range. The new category of non-intubated ARDS created for patients on high-flow nasal cannula. Again, they have to have a flow rate greater than 30 liters a minute who otherwise meet ARDS criteria. And they modified the definition for ARDS for resource variable settings not capable of having, again, an ABG. So looking at a PaO2 FiO2 ratio, not having the capability of applying PEEP, whether that's invasive or non-invasive mechanical ventilation or CPAP. Remember, PEEP has to be equal to or greater than 5 or does not have the capability of high-flow nasal cannula. So ultimately, guys, it really does allow us a much wider optic. It gives us a much better ability to assess these patients. And I love that they really looked at this from the low resource capable settings. And I would almost say that the majority of EMS agencies around the United States or around the world, they can't do an ABG. They can't even do a venous evaluation of gases. And so without some of that technology, without a mechanical ventilator, without the ability to apply PEEP continuously, without the ability to raise mean airway pressures, etc., there was really limited ways to truly diagnose patients in ARDS. So again, hopefully this is enlightening. You can apply this immediately. I will put this paper in the show notes. Again, if you have any questions, please email me, eric.bauer@FlightBridgeED.com.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.